Hello, this is Dr. Gary Rose, and this is a lecture about the state of the science regarding cannabis, what we know about cannabis. Before we start, if you want a nice comedic introduction to the history of cannabis, take a look at the first scene from Pineapple Express when you get a chance. If you got some other time on your hands, this is a lovely little book, Cannabinoids in the Brain, published MIT Press 2017. This text will tell you everything you ever needed to know about the cannabinoid system in the brain, which we'll see from this lecture is just an absolutely fascinating brain system. We could easily spend 10 hours discussing cannabis, as the information about the cannabinoids has burgeoned over the last few years, with old assumptions refuted and new assumptions postulated. Cannabis and the cannabinoids are complex drugs of intoxication, with some properties similar to other drugs of misuse and many unique properties. For example, there is solid evidence of a cannabinoid tolerance withdrawal phenomenon, but the mechanisms of action behind this phenomenon are not the same as those of either the depressants or the stimulants. There are cannabinoid-specific neuroreceptors in various brain regions, as with the opioids, and we will discuss the function of endogenous cannabinoids in this lecture too. Also, although cannabis is asserted in the popular press to have high addictive liability, there is very little evidence of cannabis craving level addiction, and this is explained by the lack of or minimal activity of cannabis at the dopamine receptor sites. Lab rats find a toke of the doobie to be non-reinforcing and will routinely select sucrose, water, or reruns of Gilligan's Island over a cannabinoid. So we've got this drug of abuse that is fundamentally different in very many ways from heroin, other opioids, alcohol, nicotine, and cocaine in terms of what it does to the brain and the addictive liability. Cannabis-dopamine connection. Historically, there has been the assertion that the cannabinoids simply do not impact the midbrain or prefrontal cortex dopamine systems. Recent evidence has indicated a more nuanced and convoluted connection between cannabis and the DA system. It does appear that exogenous, i.e. coming from the outside, cannabinoids do indeed result in elevated dopamine. However, the pathway of action is very indirect, precursed by the action of the cannabinoids on the glutamatergic, GABAergic, and opioid receptor systems in the brain. This yields a weak connection between cannabinoid use and the DA incentive sensitization reward system. The DA incentive sensitization reward system, by the way, is the fundamental brain system that is involved with true craving level addictive behavior. It remains very unlikely because of this that an individual will develop craving level problems as a function of cannabis use per se. Now, this does not mean that an individual with a brain sensitized by other drug use, for example, cocaine, may not be primed by cannabis, but rather the average cannabis user is very unlikely to ever demonstrate full-blown craving level addictive behaviors. This means that those who are labeled as, quote, weed addicts are most likely at a more compulsive psychological need level of misuse, where the problem is better understood as a function of a complicated interaction of psychological, behavioral, and contextual factors, rather than as an addiction, quote unquote, in the technical sense of the word. It is as if she is addicted to weed, as opposed to he is indeed addicted to cocaine. The endogenous cannabinoid system is a marvel of nature whose secrets are just starting to be revealed in the laboratories. Cannabinoid receptors in the human brain were first identified about 25 years ago. We now know that there are two types of cannabinoid receptors in the human brain, CB1 and CB2 receptors. Where there are receptors, there are also endogenous, internally synthesized neurotransmitters. And where there are both of these, there are natural functions associated with these structures. The first endogenous cannabinoid to be identified was anandamide, a low-efficacy CB1 agonist. Low efficacy refers to the fact that the transmitter does not have a high affinity for the receptor, i.e., it doesn't attach to the receptor in a rapid or efficient manner. Low efficacy neurotransmitters can be quote unquote bumped off the receptor by higher efficacy chemicals, and they will also have less of an effect, whatever that effect is or might be. 2-AG, a higher efficacy endogenous cannabinoid which binds to both the CB1 and CB2 receptors, was discovered after anandamide. So what is the function of this naturally occurring system of receptors and neurotransmitters? We still do not have a solid understanding of this, in part because of limitations on availability of exogenous cannabinoids for experimentation. What we do know is that the endogenous cannabinoid system is involved in various and disparate functions, including large muscle activity, anxiolysis, and may also be implicated in the diathesis of schizophrenia and other psychotic disorders. More about this later. The manner in which the endogenous cannabinoids are synthesized is unique among chemicals related to drugs of misuse. Whereas most other neurotransmitters are synthesized and stored for later release, the cannabinoids are synthesized more on a, quote, on-demand, end quote, basis. Their precursor chemicals are present in the fat cells and are rapidly converted into cannabinoids, but only just when needed. Exogenous cannabinoids vary in terms of their intoxicating effects as a function of CB1 efficacy. THC is a low-efficacy CB1 agonist. The reason that the synthetic cannabinoids, e.g. spice, are so much more intoxicating and dangerous than our naturally occurring THC products has to do with the increased efficacy of the latter with regard to these CB1 receptors. The synthetic cannabinoids bind more rapidly and effectively, and therefore yield a more intense intoxication and psychotomimetic effect. So it's not simply that the synthetics have a higher concentration of THC. The nature of the THC from the weed differs from these synthetic products. The nature of the THC in synthetic products is fundamentally different from the nature of THC in weed. CBD, a second cannabinoid found in the weed, is interesting as it does not primarily bind to the cannabinoid receptors. This accounts for the relative lack of intoxicating effect of CBD ingestion and its primary effects of anxiolysis, sedation, etc. It's a different kind of chemical impacting different brain systems. Again, the problem with the synthetics has both to do with the amount of THC per dose and the increased affinity of the synthetic cannabinoids for the CB1 receptors. This yields both a much more intense high and also all sorts of major health and well-being risks. Go natural. A lovely recent quotation that cautions us to be clear-headed about the unique and complex nature of the exogenous cannabinoid brain neurophysiology relationship. Weed is not simply heroin, gin, nor cocaine that gets rolled up in a cigarette wrapper. The connection between the dopamine receptors and heroin, alcohol, or cocaine use is much clearer than the connection between THC and endogenous neuroreceptor systems. This photograph has very little to do with this lecture, but I really like it. Some fun facts about how THC moves through your body. Remember first that the most rapid way to get a substance into your brain is via the lungs. So smoking cannabis is the most efficient means towards intoxication. THC rapidly passes through the blood-brain barrier, entering the brain within seconds of having been ingested through the lungs. Brain levels rise for 30 minutes and then diffuse over 1 to 3 hours. Oral THC yields a less efficient, as some THC is first metabolized in the liver before being transported to the brain, and longer lasting state of intoxication. Less efficient, smaller percentage of THC gets into the brain. It gets into the brain slower and stays in there longer. The phenomenology of the high of oral versus smoked is very similar if one accommodates for the lost potency versus first pass metabolism. By the way, the typical levels of THC in street cannabis have increased threefold in the last 20 or so years. This is what accounts for the changes in experienced high, moving the THC experience away from anxiolysis, anxiety management, and closer to that experienced with hallucinogenics. THC Pharmacokinetics. How is it that different people experience such a different THC high? There are significant individual differences in both the rate of absorption and the rate of metabolism of THC. Thus, individuals will experience differences in intensity due to absorption and duration due to metabolism. Also, as with all other drugs of intoxication, there are strong expectancy effects, such that positive expectancies in particular mediate the intoxication experience. What you expect to be the positive effects of smoking or ingesting THC actually impact what you experience. There is solid evidence of a marked tolerance effect secondary to repeated use of THC. This is a function of morphological changes in the CB1 receptors. Tolerance develops rapidly and also extinguishes rapidly after brief periods of abstinence. Tolerance goes up very quickly and also decreases very quickly to baseline with a short period of THC abstinence. As mentioned, there are marked differences in the THC metabolic rate across individuals. THC is stored in lipid, fat cells, and is released over time in an erratic and non-linear manner. Thus, it is difficult to predict when an abstinent individual will show negative on a THC urine or blood test. We do know that, other individual differences aside, lipid release and subsequent metabolism is slower in chronic users and/or users with a higher body mass index. Although there is clear evidence of a cannabis tolerance syndrome, there is more controversy regarding the parameters of a cannabis withdrawal symptom. Most of the research on the cannabis withdrawal syndrome has been limited to chronic heavy users, so we cannot generalize to occasional or non-heavy users. We also know that the cannabis withdrawal syndrome is very short-lived. The neurophysiological mechanisms behind CWS are unclear, but we do know that the process is not related to action at the dopamine receptors, and that there is very little evidence that CWS prompts reinstatement of use or reuse, as suggested by the classic opiate or opponent process model of addiction. This, paired with the absence of a dopamine-mediated proponent process of addiction, strongly contraindicates the assertion that THC results in craving level or true addiction. There is tolerance and withdrawal. The processes are different from tolerance and withdrawal as manifest in depressant drugs like opioids, alcohol, barbiturates. That paired with the fact that there's very little direct activity at the dopamine system in the midbrain, which is the site of the addictive process in drugs of high addictive liability, again, heroin, alcohol, cocaine. Take those together and you have a strong and convincing case against the presence of craving level, severe drug addiction as a function of THC use per se. Data from an ABAB study of THC use, focusing on the manner in which aggression, restlessness, decreased appetite, and sleep difficulty vary as a function of THC use and abstinence. You can see how these symptoms of cannabis withdrawal go up as a function of abstinence and drop down. Irritability, a symptom of CWS, peaks the first week of abstinence and then returns to baseline in 3 weeks, more or less. So again, we have evidence of a withdrawal syndrome. We also have evidence of a time limit to this withdrawal syndrome. So, is cannabis bad for your health? What we see here are the conclusions from a well-regarded review of the subject submitted for publication in 2012. Various impacts on cancer, some pulmonary problems, urological, gynecological problems, some cardiovascular impact, etc., etc. And now we'll look at the conclusions from the 2017 report from the National Academies, the premier institution for this kind of health documentation in the United States. Substantial evidence, significant health effects. The institutes reviewed all high-quality investigations of the positive and/or negative effects of cannabis on human health. They reported substantial evidence, the highest evidentiary level, of positive effects of cannabis on these symptoms and conditions. Note that cannabis is an effective component of treatment for chronic pain, as well as a variety of problems associated with multiple sclerosis. Interestingly, there is clear evidence that cannabis is an aid for short-term sleep problems, at least those associated with the above syndromes. The absence of inclusion of other conditions in this list does not indicate that cannabis is not of therapeutic utility. It simply indicates that at this time, there are not sufficient studies to support or refute that assertion. We've had such limitations in terms of the kinds of disorders that we've studied with respect to the use of cannabis as a medical intervention that we just don't know what we don't know. Again, we see that cannabis is effective in the treatment of multiple sclerosis-related symptoms, in this case, depression. Interestingly, there is limited evidence that cannabis is effective in the amelioration of social anxiety, even though the experience of many users is that cannabis increases anxiety and sometimes induces panic. So again, we're not quite sure what's going on there. We don't have enough data yet. Here are some interesting data. Cannabis use is correlated with an increased incidence of chronic bronchitis in long-term users. This is a non-controversial finding because just about any long-term use of inhalants increases lung irritation and infection. One's lungs are quite vulnerable to any chronic irritation. However, what is of great interest is that cannabis improves pulmonary function when used to remedy an acute pulmonary crisis. So if you are having an asthma attack and don't have your bronchodilator handy, smoke a doobie. On the negative side, there are some concerns that cannabis increases the risk of a negative cardiac event. However, it also decreases the incidence of metabolic syndrome, a huge problem among individuals who take a variety of psychotropic medications, including most bipolar disorder and mood stabilization medications, and the antipsychotics. So a lot has changed with regard to what we know about the positive and/or negative health consequences of cannabis use. Most of the conclusions from the 2013 Gordon et al. Review have not held up over time. There is every indication that the next edition of the Institute monograph will have even more substantial evidence of the positive relationship between cannabis use and health. A few more interesting data points from the NASM report. Cannabis intoxication does indeed increase motor vehicle accidents, in opposition to the firm beliefs of 4 million teenage doobie drivers. The humans at greatest risk of a cannabis-induced health crisis, however, are young children who accidentally ingest cannabis edibles. And nobody dies from cannabis overdose, even the little rugrats. They get sick, but they recover. Who is most vulnerable to developing a cannabis misuse problem? It's the usual cast of characters, young male garbage heads who, along with school truancy, law-breaking, fighting, and early sexual activity, also drift into early onset cannabis use. This is the general deviancy phenomenon that has been discussed in the literature for the last 30 years. A little more from the NASM report. Although cannabis can trigger positive psychotic symptoms in those for whom they are not currently present, if you already have a psychotic disorder, cannabis will remedy the cognitive dysfunction that's almost universally observed in people with acute and chronic psychosis. Cannabis use may trigger psychotic symptoms that appear to be similar to schizophrenia, but really aren't. If you are a person with schizophrenia or an acute psychotic disorder, cannabis will actually mitigate some of the symptoms. Cannabis also both mitigates social anxiety and also exacerbates social anxiety. We have evidence on both sides of that coin. Obviously, these data need further augmentation. Does chronic cannabis use cause irreversible cognitive impairment? This recent meta-analytic study suggests not. 3 meta-analyses have all indicated that cannabis-related cognitive impairment resolves after 25 to 30 days of abstinence. Once the THC residuals have left your body and cannabis withdrawal has resolved, one returns to baseline level of cognitive functioning. The so-called cannabis-related amotivational syndrome and related executive cognitive function deficits likely either predate the cannabis use or are signs of another cognitive or psychological disorder. Put down the doobie and earn a Nobel Prize. There has for many years been an assertion that cannabis use triggers schizophrenia in vulnerable individuals. Although this assertion has now been refuted, there is evidence that cannabis can produce a wide array of schizophrenia-like symptoms, especially with chronic long-term use. At this point, the most accurate assertion is that cannabis can induce a cannabinoid-specific psychotic syndrome that is not directly related to schizophrenia, nor does it seem to induce schizophrenia. The term coined for this is cannabis-related recurrent psychosis. What is most interesting about this cannabis psychosis connection is the derived hypothesis that the cannabinoid system may be involved in the etiology of true schizophrenia. This would be a wonderful discovery, as the experimental psychopathology of schizophrenia has been advancing at a snail's pace for the last 25 years, as has the advancement of neuroleptic therapies. Discoveries of the endocannabinoid system, psychosis connections, may open doors both on the theoretical and treatment sides of the house with regard to our understanding of the etiology and treatment of schizophrenia and related disorders. If the last 2 decades in the world of neuropsychology have the decades of dopamine discoveries, we are now entering the decades of the endocannabinoid system. This ends our introductory lecture on the world of cannabis, what we know and what we don't know. This is Dr. Gary Rose. Thank you very much for listening. If you're curious about this subject, you want more information, please contact me at my website, GaryRoseTraining.com.